Hi, this is Kevin Wade. I'm a palliative care physician at Kelowna General Hospital and the BC Cancer Centre for the Southern Interior. I'm one of the authors and originators of the new Refractory Symptoms and Palliative Sedation Clinical Decision Support Tools, along with Elizabeth Antifo and Vicki Kennedy, who are clinical nurse specialists. In this upcoming 20-minute presentation, I'm going to be discussing how to use the new clinical decision support tools, and in particular the pre-printed order to help using palliative sedation for your patients suffering from refractory symptoms at end of life. This presentation is intended for the ordering clinician, namely the physician or nurse practitioner who will be filling out the PPO. So first, I'd just like to speak briefly about palliative sedation therapy. Palliative sedation is the administration of sedatives to help alleviate refractory symptoms for patients with intolerable suffering and refractory symptoms at the end of life. The typical symptoms this is used for include delirium, shortness of breath, pain, and nausea. And these are symptoms that don't respond to usual and optimized symptom treatments such as opioid analgesics or antiemetics. It should be a relatively rare process to use palliative sedation, but it certainly can help some patients and families dealing with a very difficult situation at end of life. The particular clinical decision support tools used here with our palliative sedation protocol came out of the initial endorsement of the BC Refractory Symptoms and Palliative Sedation Symptom Management Guidelines that were endorsed for clinical use back in October 2019. These are a set of provincial guidelines developed by the BC Centre for Palliative Care, and they include guidelines for palliative sedation. In order to help operationalize these guidelines, we developed a package including these pre-printed orders and other clinical decision support tools to help clinicians actually use these at the bedside. During development, the palliative sedation toolkit underwent several rounds of stakeholder reviews, which resulted in multiple improvements both to the PPO and the other support tools. Stakeholders included clinicians, pharmacists, nurses, allied health professionals, and in particular, I'd like to recognize the contribution of the Patient Voices Network, which provided clear, patient-focused, and patient-centered language for the patient and family information handout. We also sought feedback on the ethical and legal implications of the palliative sedation protocol, along with feedback from the Professional Practice Office and the Quality and Risk Management Office in order to ensure that the palliative sedation protocol was clear, readable, and usable both for the ordering clinician and the nursing staff. So now that you have some background, we can talk specifically about the nuts and bolts of the palliative sedation clinical decision support tools. We'll be going through each of these 8 tools in order, focusing mainly on the first one, the palliative sedation pre-printed order, and its use by the ordering clinician. So the palliative sedation pre-printed order is a key document that we'll be coming back to later in the presentation. For now, just know that the PPO includes medication recommendations that are in alignment with the first, second, and third line drugs in the provincial symptom management guidelines that I mentioned earlier. The intent of the palliative sedation PPO is to provide clear direction for the indications and monitoring parameters of palliative sedation, along with recommended consent and medication advice for the ordering clinician. It provides dosing guidelines that are drawn directly from the provincial symptom management guidelines to help the ordering clinician choose a dose and a consistent medication that should provide sedation for the patient to the intended target. We'll be coming back to this later on in the presentation, and we'll talk specifically about each of these aspects. The palliative sedation checklist is a recommended tool to assist the clinician in organizing palliative sedation therapy. The purpose of the checklist is to assist in guiding all practical and ethical considerations when considering potential palliative sedation therapy, and can help the clinician determine whether palliative sedation is appropriate for this patient in this location. Once completed, it should be part of the client chart, but as a reminder, it's not a required but a recommended tool to help clinicians organize themselves prior to discussing and potentially initiating palliative sedation therapy. The palliative sedation algorithm is a flowchart meant to assist the clinician in a decision process as to whether palliative sedation is appropriate for this patient and how to continue and adjust palliative sedation once it's been initiated. It encompasses both the patient-centered and family-centered decision-making involved in considering palliative sedation, along with clinician-oriented decision-making once palliative sedation has been started. One of the most important and useful documents in the toolkit is the Palliative Sedation Patient and Family Information Sheet. This was tested with the Patient Voices Network and includes clear, simple, and patient-centered language to help describe what palliative sedation is, why it might be used, and what they can expect if palliative sedation is started. It can certainly be helpful when discussing palliative sedation with patients and their family, and when considering whether it might be appropriate for a particular patient. And it can help the families understand what's going on once palliative sedation has been started. The palliative sedation monitoring record is mainly for the use of nursing staff to help titrate an infusion or intermittent delivery of medications for palliative sedation. It can also be reviewed by the ordering clinician in case they are uncertain of whether the level of sedation is appropriate or whether the patient is actually comfortable. It improves on previous practice where PRN medications were typically given without goal-oriented palliative sedation, in that it requires monitoring of a number of different parameters, including the Richmond Agitation Sedation Scale, the Pain AD Scale, and the Respiratory Distress Observation Scale. This allows nursing staff to quickly and succinctly communicate a level of comfort and level of sedation to each other and to clinicians, and allows the medications to be titrated to maximum effect. The Richmond Agitation Sedation Scale is a standardized and validated instrument normally used for measuring sedation levels in the ICU. RAS-PAL is a variant which is used mainly for palliative care use and does not include painful stimulus to help determine the sedation level of the patient. Instead, it uses observational cues to determine the patient's level of sedation. The RAS-PAL is included both as a separate document as well as being on the back side of the first page of the palliative sedation PPO. Of note, the typical sedation level that we recommend for patients with palliative sedation is level -3 or moderate sedation. However, this can be adjusted by the ordering clinician if they feel that a lighter or deeper level of sedation is necessary for patient comfort. The RDOS, or Respiratory Distress Observation Scale, is another standardized tool to help the clinician assess the intensity of dyspnea in patients undergoing palliative sedation. It's a validated scale that has been measured against patient-reported dyspnea and can be used for those unable to talk and report their own shortness of breath. It's included both as a separate document, again, as well as being on the back side of the first page of the PPO. The intent of this is to allow measurement of shortness of breath in patients who can't report it themselves, and allow the clinician to make appropriate adjustments, including things like opioid analgesia, in order to minimize patient dyspnea. The third and final tool that's available as part of the palliative sedation toolkit is the Pain Assessment in Advanced Dementia Scale, or Pain AD. This is available both as a separate document as well as being on the back side of the first page of the PPO. This is a tool that's been previously used within Interior Health for assessing pain in patients with severe dementia who are unable to verbally report their pain. And we're using it here to help separately report pain in patients undergoing palliative sedation. It's important to have a separate pain assessment scale alongside the Richmond Agitation Sedation Scale, as many of the sedatives that are used for palliative sedation are not actually analgesics, and patients can still be experiencing pain even without any outward signs of it because of moderate to deep sedation. It's important for clinicians to monitor these cues at the bedside and determine whether patients are in pain so that appropriate analgesia can be prescribed even in sedated patients. So now that I've introduced the toolkit and package of clinical decision support tools, I'd like to change gears and focus in specifically on the palliative sedation pre-printed order, which is the tool that most clinicians are going to be filling out. The palliative sedation PPO is a 2-page pre-printed order with useful information printed on the back side of both the first and second pages. Shown here is the first page of the PPO. I'd like to draw your attention firstly to the MOS status and the statement that patients must have a MOS status of M1 documented and submitted on their chart. Next, we're going to move on and talk about patient consent. As with any medical procedure, palliative sedation requires patient or substitute decision maker consent in order to proceed. As well, in order to meet clinical standards, palliative sedation should only be used in situations where the patient is actually suffering from a refractory intolerable symptom. And in planning for palliative sedation, clinicians should reassure themselves that they have in fact tried everything short of palliative sedation in order to help resolve this symptom. Consent does not need to be written from the patient, family, or substitute decision maker, but it should be discussed with them and documented by the clinician in the chart. In addition to the patient and substitute decision maker, it's often useful to have a discussion with the interprofessional healthcare team, including bedside nursing staff, to make sure that the setting is appropriate and that the entire care team is on board with using palliative sedation for this patient. The PPO also includes a monitoring section to help establish the sedation goal for this patient, as well as to establish how to monitor the patient while they're undergoing palliative sedation. The recommended sedation goal is a level of -3 or moderate sedation, which means that the patient may move or even open their eyes to voice, but will not maintain eye contact. If desired, another level of sedation can be established for either deeper or lighter sedation, depending on patient and family values. It also establishes the 3 sets of monitoring parameters, namely the RAS-PAL, the PAIN-AD, and the RDOS, which are used by the bedside nurses in order to help monitor and titrate medications to optimum effect. Now moving on to page 2 of the PPO, which includes all medication orders associated with initiation and maintenance of palliative sedation. Of note, on the back side of page 1, there's a smaller copy of the Richmond Agitation Sedation Scale, the PAIN-AD scale, and the Respiratory Distress Observation Scale to help the ordering clinician. The first thing to note here is that patients undergoing palliative sedation will no longer be able to take oral medications, so those will all be stopped. There's also sections, obviously, for sedatives, and we'll discuss analgesics as well. Finally, you can note up near the top of the sheet that there's an order for either glycopyrrolate or atropine to help patients with respiratory congestion at end of life. There are 4 medications listed for palliative sedation, and we're going to discuss the first 2 here, which are midazolam and methotrexate. Midazolam is the recommended first-line medication for palliative sedation because it has a short half-life and can be used for rapid titration to effect. If the patient is oversedated, it's easy to lower the infusion rate and bring them back to an appropriate level of sedation, while also not leaving them with suffering for longer than they need to during initiation. Midazolam can be given as both a subcutaneous or IV infusion, depending on the setting, as many of our hospice and long-term care settings are unable to deliver IV medications. In acute care, it may be more useful to do this as an intravenous infusion, depending on the skill and familiarity, especially of the nursing staff involved. The second line option for palliative sedation is methotrexate, commonly known by the old brand name Nazanan. This again can be administered both as a subcutaneous or intravenous injection, and it's an intermittent injection typically given as a Q8H regular and Q2H PRN dose. The recommended range is listed here, and it has good subcutaneous bioavailability such that we use the same dose for subcutaneous and intravenous use. Prior to the palliative sedation protocol, many clinicians used methotrexate for this purpose and managing agitation at end of life. In this case, we can still use methotrexate, especially in patients or settings where people are uncomfortable with continuous infusions. And in that case, the palliative sedation protocol will really just add the monitoring and consent pieces to what was previous practice. We would expect that midazolam and methotrexate can be used in the vast majority of patients for palliative sedation at end of life. However, the PPO does provide for 2 more medications for 3rd and 4th line therapy. These are listed here. Phenobarbital as the third-line medication, is typically recommended for patients who are having seizures or at high risk of seizures at end of life and who are in a setting that's not capable of delivering a continuous infusion like midazolam. It's difficult to titrate, and if you're using this, I would recommend consulting with an experienced palliative care physician who has previously used it. The fourth-line medication is lorazepam, which is another benzodiazepine like midazolam, but one with a longer half-life and slightly more difficult to titrate. The main benefit of lorazepam is that it's available as a buccal or sublingual administration for patients, which may allow us to do palliative sedation in the patient's preferred setting, including home or long-term care, if you have the appropriate tools and skilled clinical staff available to provide that care. I also want to speak specifically about analgesia. We avoided describing or prescribing specific analgesia on the palliative sedation pre-printed order, other than recommending that pre-existing parenteral analgesia be continued, such as intravenous or subcutaneous hydromorphone or morphine. It's important to note that other than methotrexate, none of these sedative medications have any analgesic effect, and therefore patients can still remain in pain while sedated. Because of this, it's important to ensure that patients' pain is being appropriately managed, and that if patients are on oral analgesics, they should be switched over to an appropriate parenteral counterpart. If you have trouble doing this, you can consult with the palliative care physician, including on the provincial palliative care consult hotline. We did not want to make specific recommendations about how to do this because it was outside the scope of palliative sedation in the PPO, but would be happy to help clinicians use this in practice in order to help benefit their patients and reduce pain during sedation at end of life. So that concludes this lecture on the new palliative sedation pre-printed order and the clinical decision support tools available to help clinicians use palliative sedation for their patients with refractory symptoms at end of life. This clinical decision support tool is just being released now in May 2020, and we have an implementation plan consisting of promulgation on InsideNet, along with wider communication out to physicians and caregivers throughout Interior Health. We're also excited to hear your feedback as you start to use the pre-printed order and the other tools in the toolkit. The email addresses and phone numbers for feedback are listed on this slide, and they're for the clinical nurse specialists Elizabeth Antifo and Vicki Kennedy, who were my co-authors and contributors in developing the palliative sedation protocols. Thank you very much for listening to this presentation. We're very excited and hopeful that the palliative sedation PPO and clinical decision support tools will help to improve care and relieve suffering and refractory symptoms at end of life for patients throughout the health authority. Thank you again for all the care that you provide.